Next session will be on diplopia. Here we will try to talk about non-neurological causes of diplopia. This talk will be under 4 headings. First, I will try to talk about the refractive causes for diplopia. Then, Dr. Samyukta will be talking about comitant strabismus, and followed by Dr. Chaitanya, who will be talking about orbital causes, and finally Dr. Divya Kishan will be talking about binocular causes for diplopia. So, coming to the first talk, diplopia due to refractive anomalies. So, the refractive aberrations which causes diplopia can be talked under 2 headings. One is refractive errors, and other one is media abnormalities. So, we will try to talk about a small case. This is a 60-year-old male patient who had done his cataract surgery 1 week prior, and he came with complaints of diplopia. So, a patient with diplopia, like in any other case, we take a good history. We try to know the onset of the diplopia, duration, any associated symptoms. So, one important thing is we need to know is if it's a binocular diplopia or a monocular diplopia. So, we ask the patient, sometimes the patient will tell us when he or she closes one eye or either eye, the diplopia resolves. So, this patient said he is having diplopia monocularly, and we can confirm it by doing a cover test. We cover either eye and see if the diplopia resolves. So, the monocular diplopia mechanisms can be dealt under 3 headings. First, light diffraction, then metamorphopsia, and cerebral polyopia, which can cause bilateral monocular diplopia. So, what is light diffraction? It's a property of the light rays to bend around the corners of an obstacle. So, here as you can see, the light rays met with an obstacle and it bends around that obstacle. So, this property is called light diffraction. So, what happens is that when there is an opacity or aberration in the optical system, the image of an object can fall on the fovea and the extra foveal retina of the same eye, and this can lead to diplopia. So, what does a pinhole do? A pinhole will cut that diffraction, and only the foveal image will fall on the retina, and the diplopia will resolve in such cases. The second mechanism of monocular diplopia is metamorphopsia. As you can see, some retinal pathology like ERM can cause distortion of the retinal images, and here it does not resolve with the pinhole. Cerebral polyopia is a different topic and we will skip that. So, coming to our case, the patient complains of monocular diplopia. So, the next thing we can do is do a pinhole test, and in this case the diplopia resolved with a pinhole. So, the cause mechanism may be a light diffraction. So, the light diffraction, 2 causes are refractive errors or an ocular media abnormality. So, we did a manifest refraction for the patient, and patient had mixed astigmatism with 1.5 diopter cylinder and 2.5 diopter cylinder at 110, and the patient vision was 618. So, next we have to do a slit lamp examination to look for any ocular media abnormalities, and the slit lamp examination is within normal limits. We have to do a objective refraction, retinoscopy refraction, which showed higher astigmatism with minus 3.5 diopter sphere with the 6 diopter cylinder, and the patient vision improved to 6.9 from 6.18, and the diplopia gets resolved. So, this is a case of high refractive error, high astigmatism, which caused the monocular diplopia. So the tight suture may be causing the problem, and the suture removal will reduce the diplopia. So the refractive errors which can cause diplopia can be a high ametropia or irregular astigmatism, as in this case. Anisometropia can cause anisoconia in cases and even cause binocular diplopia. So the take-home message in this case is objective refraction is mandatory during the evaluation of binocular diplopia, because subjective refraction can be unreliable, especially when the vision is poor. The next thing is about the media abnormalities. Any abnormalities from the anterior to posterior can cause light diffraction and monocular diplopia. So it can be a lid tumor which compresses the cornea, or a tear film abnormality, or any corneal opacity or irregularity. It can be multiple pupil like polychoria, and it can be an abnormality in the lens which cause diplopia. This is another case, a 25-year-old male presenting with the diplopia, headache and dizziness. And from the symptoms and from the evaluation, patient is having monocular diplopia. His vision was 6.9 in the right eye and 6.6 in the left eye. So we have to do a pinhole test, and the pinhole test, the symptoms resolved. So we have to do a slit lamp examination, and slit lamp examination showed a lens opacity in the central visual axis, a well-defined circular opacity. And the rest of the examination were within normal limits. So this was a case of lens causing diplopia, and a phacoemulsification surgery resolved the patient's symptoms. So like in the last case, a cataract can cause monocular diplopia. Post-surgery, a subluxated lens or descended lens can be another cause. Even a vitreous opacity like an intraocular foreign body can cause light diffraction and thus diplopia. So to summarize, the diplopia, one main thing is we have to see is monocular or binocular diplopia. So if it's a monocular, it can be even bilateral, like in cerebral polyopia, or usually unilateral. If it's a unilateral monocular diplopia, the next thing we have to know is if it's due to a light diffraction mechanism or metamorphopsia. So we have to do a pinhole test, and if the diplopia persists with the pinhole, we have to look fundus for any maculopathy. We also have to do a good objective refraction in such cases. And slit lamp examination to look for any media abnormalities. This is another important instrument which will help us during this assessment. As in, we can get an idea about the astigmatism or any refractive errors by seeing the red reflex. We can even know, identify the media abnormalities like keratoconus in this patient. And we can know if the opacity is in front of the pupillary plane by looking at the movement of the reflex. Like if it moves along with the eye movement, the opacity is in front of the pupillary plane, and if it's behind the pupillary plane, the opacity will move against the eye movement, and it will be stationary in case of if the opacity is in the pupillary plane. So to summarize, a case of diplopia, we have to take a good history, do the cover test, and if it's a monocular diplopia, monocular diplopia, we have to see if it's a unilateral, and then we can do a pinhole test and see if the diplopia resolves. And if it persists, we have to look for any metamorphopsia like a fundus for maculopathy. And if the pinhole, if the diplopia resolves, we have to look for any refractive aberrations, and we do have to do a good slit lamp examination, refraction, and direct ophthalmoscopy. These are for the further reading. Thank you.
Thank you, Naveen, for that very comprehensive talk. Now, may I request Dr. Samyukta Sadashivan, Assistant Professor of Ophthalmology in Government Medical College, Thrissur, to speak to us on the topic diplopia in comitant strabismus.
Good morning. So, strabismus, which is comitant, signifies that the misaligned eyes maintain their abnormal relation to each other in all directions of gaze. So, when you measure the deviation, the magnitude will be the same in all gaze positions. So, here the efferent pathways are essentially normal, and the problem lies in the afferent pathway. So, the central mechanism mediating fixation and fusional reflexes is either underdeveloped or has broken down. So, that usually diplopia is very unusual in comitant strabismus. Why? Because of development of neural suppression mechanism, or due to development of amblyopia in children, or due to anomalous retinal correspondence. There are situations where you can expect a diplopia to occur in comitant strabismus, and that happens spontaneously. Heterophoria when fusion fails, when suppression fails, in association with a significant change in the degree of strabismus, or in cases of long-standing strabismus, when a disruption in visual adaptation happens, rarely after orthoptic treatment and also post-operatively. So this was a 12-year-old boy who presented with a history of binocular diplopia of 1 week duration. There was no contributory family history or any precipitating event. His squint evaluation revealed 45 prism diopters of esotropia for both distance and near, alternating well, full extraocular movements. Worth 4-dot test revealed that the patient said he was seeing 5 dots, suggestive of binocular diplopia. His best corrected visual acuity was 6.6 and N6. Cycloplegic refraction was within normal limits. Fundus exam also suggested nothing abnormal. So this being a case of acute onset ESO deviation, we went ahead with an MRI that turned out to be normal as well. So a diagnosis of acute acquired comitant esotropia was made. Now, this is a clinical entity which mandates good attention these days, especially after the post-COVID home confinement times, and increased number of cases have been reported ever since. So the clinical features, salient features include acute onset, association with diplopia for both near and distance, comitant nature of the deviation with the difference less than 5 prism diopters in all gaze positions, values being similar for both distance and near. And it is a large angle esotropia typically with full extraocular motility in all directions, seen usually in older children more than 5 years and also in adults, and accounts for nearly 0.3% of childhood strabismus. Etiology is essentially elusive. Mental stress, increased screen time, and decompensation of esophoria have been hypothesized to be causing this. So this is an interesting article which got published from Kerala in the COVID times. Similar reports have been published in the past as well. All of them point towards the fact that the stronger convergence and lack of distance stimuli create an imbalance between accommodation vergence mechanics, and that further leads to dynamic activation of medial rectus muscles. So regarding the course and prognosis, there is a 6% risk of an underlying neurological disease, so neuroimaging is mandatory before you take up the patient for any surgical intervention. Recovery spontaneously is unusual. The main concern in children is the possible development of suppression. So as step 1, you can advise refrainment from near work, reduce screen time and reassess, and a waiting period of 3 to 4 months is advisable before taking up for any surgery. And you have to differentiate AACE from these different conditions: 6th cranial palsy, cyclic esotropia, divergence insufficiency, refractive esotropia, spasm of near reflex, and finally myasthenia gravis. With early intervention, this condition has got an excellent prognosis. Spectacle correction has to be considered after going for a thorough cycloplegic refraction and attending to the accommodative component. Botox is a viable option to maintain binocularity during the waiting period. And if the amount of deviation is close to 15 prism diopters, you can even try a base out prism to maintain binocularity till the deviation stabilizes. Surgery, as I told, after 3 or 4 months till the deviation stabilizes. And another interesting point is that we have to go for a wider surgical dosage than those reported in dose response tables for esotropia. So Botox, this is a rough guideline. You can give a range of 4 to 7 international units for deviations ranging from 30 to 60 prism diopters. Monoocular upper lid ptosis is a concern, but it is something which resolves on its own. So this child was given 5 international units of Botox A under GA to his left medial rectus. He developed a ptosis in the immediate postoperative period, but it was transient and resolved on its own. However, at 2 months post-op, he was orthophoric. So this is a second patient, a 30-year-old artist who gave a history of 5 years of sudden onset ocular deviation with horizontal diplopia. He gives a history that he developed these symptoms immediately after working with phone for 5 hours continuously. He himself being an artist, he used the phone for drawing pictures. And on that particular day, he developed this sudden onset left inward deviation, right eye inward deviation with associated horizontal diplopia. And he consulted elsewhere, and in these 5 years, he underwent 2 procedures, like Botox was given twice. So on evaluation, cover test revealed alternating ET with left dominance. Prism cover test showed 30 plus 40 prism diopter CT for both distance and near. EOM was full. Visual acuity, best corrected visual acuity 6.6. Cyclorefraction showed normal retinoscopy shadows. And fundus exam was within normal limits. Again, MRI brain was done. That was also normal. So this was an adult whom we diagnosed with AACE. Since Botox was already tried, we went ahead with a recess resect procedure in the right eye. Now he has a residual deviation of 35 PD ET. Now the other eye is being planned for R by R. So this is a common scenario, nothing new. A 14-year-old boy with occasional outward deviation of left eye, history of occasional diplopia and aversion to bright light. So his cover test revealed, his Hirschberg's test revealed no angle to 20 degree LXT. Cover test showed alternating exodeviation with right eye dominance. EOM full, PCT for distance 35 PDXT and for near 30. Visual acuity 6.6 both eye. BSV showed left suppression at the time of examination. Fundus examination was within normal limits. So he was diagnosed with fair control intermittent exotropia. Recess resect was done in the left eye. Post-operatively, orthophoria was achieved. So we know intermittent exotropia is the second most common type of strabismus. A large exophoria which is controlled by fusional convergence mechanism breaks down to manifest exo when the patient is fatigued. Typical symptoms, transient diplopia or a diplophotophobia. They say that the bright light dazzles the retina and that breaks fusion and the patient will experience diplopia. This is a Buren's classification of IXT, basic intermittent XT, true divergence excess IXT, pseudo or simulated divergence excess IST, and convergence insufficiency IXT. This Newcastle control scoring system is a reliable method for grading the severity of IXT. And as you work up, go for a prolonged alternate cover testing, do a patch test for 30 to 45 minutes, and to confirm high AC by A ratio true divergence excess type of IXT, you may have to go for lens gradient method, that is a +3 diopter near ad test. Management, start up with cyclorefraction and give corrective lenses accordingly. Over minus lens therapy is to stimulate accommodative convergence, and prisms and part-time occlusion can be considered. Finally, you can go for symmetrical bilateral surgery or unilateral recess resect. So this is a fourth case, a 67-year-old gentleman who presented with outward squinting of left eye, 1 year duration. No contributory history, no addictions, no prolonged medications. His cover test revealed alternating kind of exodeviation with full EOM, PCT for distance 35 PDXT and for near 40 PDXT. Best corrected visual acuity 6.6 N6. Worth 4 dot test revealed left suppression. Dilated fundus exam was within normal limits. He did not have any comorbidities either. So this was his FAT scan. All the photographs of past suggested orthophoria. So this is probably a decompensated childhood strabismus in adulthood. Advancing age per se is a causative factor that causes some imbalance between the sensory and motor binocularity. So here, probably the accommodative reserves have become deficient with age. His convergence response is affected. Refractive changes can also be a cause. Any change that forces fixation with the patient's previously non-dominant eye. So this condition has been named as fixation switch diplopia. Other causes are trauma, illnesses, or medications and alcoholism. This is an interesting article which we found in American Orthoptic Journal, where they have told in detail about decompensated childhood strabismus manifesting in adulthood. So management, first and foremost, after the essential routine investigations, you have to rule out neurologic disorders. Prisms can be tried in small deviations. Fresnel prism foils can serve as a temporary or a permanent solution in larger deviations. And Botox again can be tried. Finally, resort to surgery if the deviations are more than 10 prism diopters, preferably with the adjustable sutures. Thank you.
Next we have Dr. Chaitanya Warrior, who will be talking about diplopia causes due to orbit. Dr. Chaitanya is a consultant pediatric ophthalmologist at Chaitanya Hospital, Tiruvalla.
Good morning, one and all. Here I am going to deal with diplopia causes from orbit. Orbital causes of diplopia can be due to orbital wall involvement or orbital spaces and vascular and soft tissues in the orbit or ocular muscles. So it can be due to orbital trauma, orbital mass lesions, or orbital inflammatory syndrome and thyroid eye disease. Basically, the mechanism behind this diplopia from orbit will be either mechanical or restrictive and paralytic. Restrictive causes will be from orbital fracture with muscle entrapment, thyroid eye disease, or scar tissue due to any cause relating to the orbit, or like the orbital inflammation and restrictions due to the orbital tumor involvement. Mechanical, orbital mass lesion can limit the movements. Paralytic causes due to non-isolated cranial nerve palsies leading on to the pathology at the cranial sinus and orbital fissure. So we need to evaluate the patient with a detailed history, clinical examination, imaging is a very must, and follow-up is the underlying key. So if a patient complains with sudden onset diplopia, we are suspecting causes from the orbit. And if it is sudden onset, we will suspect vascular or ischemic pathology. If there is a pain or discomfort, it will be mainly inflammatory related orbital microvascular ischemia. If there is no sudden onset, it's long duration, basically non-vascular. And pain and discomfort is not there, non-inflammatory orbital mass related, either restriction or mechanical. If the pain is there, definitely inflammatory causes from orbital myositis, Graves' disease, or abscess or infiltration. So, if a patient with multiple cranial nerve involvement with diplopia and no neurological sign, the tug of war will be between inflammation or infection and mechanical orbitopathy at the posterior orbit or cavernous sinus. So we need to do definitely a contrast enhanced MRI of orbit with or without brain imaging. Coming to few scenarios, diplopia associated with other signs from the orbit like ophthalmoplegia, proptosis, chemosis, facial numbness, loss of corneal reflex and abnormal pupillary reflex. So definitely the diagnosis is a cavernous sinus syndrome. Need to rule out the causes. If the same case with cavernous sinus syndrome features along with vision changes, papilledema, definitely we need to look for causes from the orbital apex. If diplopia with infection, features of infection and ophthalmoplegia plus with fever and immunosuppression, we need to rule out the orbital cellulitis. If there is ophthalmoplegia with history of trauma and signs of trauma along with diplopia, we need to rule out orbital wall fracture or retrobulbar hematoma. Coming to clinical cases, 8-year-old girl came to the OPD with complaints of her diplopia. 1 month history of RTA was there. Her vision is 6/6 and she was evaluated elsewhere with CT brain and it was normal. See, on her photographs, she is orthophoric. Looking to her video, she is orthophoric for the cover and uncover test. On ocular movements evaluation, can see a very minimal limitation of elevation in the right eye. So I sent her for CT orbit. It revealed inferior orbital wall fracture with inferior rectus muscle entrapment. It's a white eye blowout fracture. Definitely the eye will be white, intact orbital rim in children with soft tissue herniation and vagal phenomena will be there. But for her, there was no vagal phenomenon. So in all cases of white eye blowout fracture should not be missed and CT scan orbit is a must. She underwent orbital floor repair and in this video can see her elevation is full and she was free of symptoms. Coming to the second case, a 6-year-old girl came to OPD with swelling and redness in the left eye with no pain. And diplopia was there while looking out and up. Uncorrected visual acuity was 6/6 and when I elevated lid, there was a reddish elevated mass in the supraorbital region suspecting acute dacroadenitis. But for that, the child will be febrile or pain will be there. See, I am lifting both eye. Very easily child is cooperating, there was no pain. So I asked mother, again fever, trauma, joint pain, nothing was there. Again with the history, I got a positive relevant history. She completed the treatment for leukemia, probably ALL 2 years back. So definitely we need to rule out the metastasis and it was a difficult situation for the mother to accept and refer to her treating oncologist. Case 3, a 10-year-old boy with pain and double vision while looking up for the 3 days. History of fever was there, vision 6/6. On examination, there was a supromedial elevated congested mass, turned out as myositis, treated with antibiotics and steroids, he resolved. Coming to the fourth case, a 65-year-old male with complaints of diplopia for last 2 years. Vision was 6/9, both eyes. On examination, there was ptosis in the left eye. Ocular movement evaluation revealed there is limitation of elevation in the left eye in all cases. And there is a reddish salmon pink mass in the upper orbit. It's a turn out as lymphoma. So always, if there is ptosis, please always lift the upper eyelid to see any underlying mass. A 33-year-old male complains of diplopia while looking to extreme right side. Best corrected visual acuity was 6/6. On gross photograph, there is a very abnormal palpebral fissure in the right eye. Ocular movements and cover test revealed it as orthophoric and ocular movements were full. He had a very minimal diplopia towards the extreme right gaze. He was a dysthyroid case and now he is euthyroid. And when the proptosis, everything resolved, the palpebral fissure asymmetry was there and he underwent a cosmetic tarsography. Coming to this lady, she complains of diplopia while looking up. This photographs reveal the eye is out, eye is down. Here our ocular movement evaluation revealed the elevation is limited and she is a case of dysthyroid, hypothyroid lady. It's because of the thyroid related issues and she was referred again to endocrinologist, and when the thyroid status become stable, if again diplopia is there, we can intervene. These two ladies are also cases of one is hypothyroid and one is hyperthyroid cases. All complaints of diplopia in extreme cases. Causes of diplopia in hyperthyroid is because of the restrictive pathology and also proptosis related the side gaze problems, and dry eye can also contribute. Here our ocular movements is almost full, but the proptosis related end gaze pathology is relating to the diplopia. A 64-year-old patient who underwent FES noticed diplopia immediate post-op. This is a 1.5 month picture, and this is 3 month post-op. Both this picture, there is growth, exotropia is there, and it revealed a limitation of adduction, gross exotropia. It's because of the medial rectus muscle was damaged during the FES surgery, and she was a little free of diplopia because that eye vision was 6/18 because of pseudophakia and PCO. So she was not willing for further management. This lady complains of diplopia on and off. You can see ptosis, but the diagnosis was proven with an eye spectus, that's myasthenia gravis. Another male patient complains of diplopia for a few months. On examination, there is ptosis and gross facial asymmetry is there. Ocular movements in the right eye's full elevation is limited. There is a fibrotic changes near the maxillary sinus along with the orbital changes. Probably maybe a fibrosis related issue or malignancy. Patient was not willing for further evaluation and lost follow-up. And coming to another case, 82-year-old female, she presented with binocular diplopia and orbital pain, 2 days duration. Best corrected visual acuity was 6/12. Anterior segment evaluation is immature senile cataract was there, fundus normal. Ocular movements, -1 limitation of abduction in the right eye. Orbital pain and tenderness was there. Suspicious evolving lateral rectus paresis, evaluated with MRI brain and orbit, turned out as early Tolosa-Hunt syndrome, treated with steroids, and she became asymptomatic. Coming to last case, 62-year-old female came to OPD with some irritation. She was 6/9 because of immature cataract, and again after 3 days she presented with diplopia. That time there was right eye evolving lateral rectus paresis, and neurology evaluation and MRI was advised. This is the second time visit. Can see a minimal limitation of abduction in the right eye. Evolving lateral rectus paresis is there in the right eye. But after 2 weeks, she again turned back with redness and ocular pain along with increased diplopia. That time redness in the right eye also. Bilateral lateral rectus paresis is there, and the imaging revealed carotid cavernous fistula. Here she is having bilateral limitation of abduction. Further evaluation turned out as carotid cavernous fistula. So for diplopia from orbit, we need to get a proper full history. Need to see it is whether monocular or binocular. Proper anterior segment and fundus examination is a must, along with ocular movements and imaging, and follow-up is another very important key. Thank you.
Thank you, Dr. Chaitanya. Over to Dr. Divya Kishan, Assistant Professor, GMC Kollam, for her talk.
So a very good morning. A very good morning, one and all. First of all, let me thank Dr. Naveen for giving me this opportunity to speak on the topic double trouble by binocular vision anomalies. So we see that there is a drastic increase in non-strabismic binocular vision anomalies these days, and the prevalence in a study by Dr. Rizwana et al. Has been shown to be about in 30.8%, with convergence insufficiency being 16% and accommodative infacility being 10.8%. So let us see the case of this 9-year-old child who complains of double vision when reading. So on examination, you find that the visual acuity is 6/6 in both eyes. The anterior and posterior segment examination with special emphasis on ocular motility is within normal limits, and the cycloplegic refraction is also within normal limits. On detailed evaluation, you find that in prism cover test, there is a 12 prism diopters, exo for near and ortho for distance. The near point of convergence is 15 centimeter and near point of accommodation is OD and O is 8 centimeters. So we come to the provisional diagnosis of convergence insufficiency. And convergence insufficiency usually presents with complaints of blurred vision, double vision, eye strain, and headache, which is due to the sustained effort to increase the fusional convergence during the near task and difficulty in concentrating. But the word of caution is that in all cases that present with double vision, do not jump into the diagnosis of convergence insufficiency. That is because for patients it is actually difficult to differentiate whether they are seeing it as blur or double. And moreover, an underlying accommodative problem can present as a secondary convergence issue. So it is mandatory that in any child in whom you suspect a binocular vision anomaly, a comprehensive assessment of the orthotics is mandatory, which includes the analysis of accommodation, vergence, and also the oculomotor function. So what are the convergence anomalies that we see? Based on the distance and near difference in the deviation, we can classify them into convergence insufficiency, divergence excess, basic exo, convergence excess, divergence insufficiency, basic ESO, and fusional vergence dysfunction. Accommodative dysfunctions that we see in common are accommodative insufficiency, ill-sustained accommodation, accommodative infacility, and also accommodative excess. So in these cases, a comprehensive evaluation, including that of accommodation, will include the near point of accommodation assessment, accommodative response by using the MEM retinoscopy, the relative accommodation, that is the NRA-PRA assessment, and accommodative facility assessment. The vergence ones include the near point of convergence, foria measurement, step vergence, and vergence facility assessment. So what are the tests that we do for convergence? The first would be to assess the foria for distance and near. Then we check the age-old near point of convergence, which we are all very familiar with. You can either use it with an accommodative target like an RAF rule, which is more common, but now we prefer more a pen light with red-green filter. That is because, especially in cases of children in whom the accommodation is very high, they will use the accommodation to overcome the convergence insufficiency, and so we may not get the real value when you look with an accommodative target. That should be done in a dim illumination, and you have to repeat it twice or thrice and take the average of these values. The third one would be a step vergence testing, where a positive fusion and negative fusion are assessed. In positive fusion, a prism bar with a base out prisms are placed in front of the eyes, and then the patient is asked to report the first blur and break in the values. Likewise, for negative fusion, the base in prisms are placed, and then the first break and break values is taken. Vergence facility is done by using the vergence flippers, which is 12 prism base out and 3 prism base in. Also, in all cases, it is mandatory to check the accommodative convergence by accommodation ratio, either by using the gradient or the heterophoria method. These are the normative data that we expect in patients with during the convergence assessment. NPC should be about 6 to 8 centimeters. And foria up to 4 exo at near is normal and 2 exo at distance. The vergence base out 23-16 and with base in 12-7, and vergence facility that should be 15 cycles per minute. Now what are the tests for the accommodation that we do? That would include the near point of accommodation and accommodative amplitude assessment. The near point of accommodation can also be checked by using the RAF rule, and the accommodative amplitude is assessed as age-based, and the Holstester's formula was the one that we used earlier, but for Indian children, Dr. Riswana et al. Has now formulated a formula 16 minus 0.3 into age, and by calculating, putting in the age in that, you can get the what is a normal accommodative amplitude for the age of the child. Now, accommodative response is done by using the MEM retinoscopy technique, whereby you are neutralizing the reflex at near by using the retinoscope when the patient is reading on an accommodative target. Relative accommodative assessment would be done by serially adding plus lenses in 0.25 sphere add-on, and then you see the first blur. You can check for the positive and negative relative accommodation values. Accommodative facility is done by using the accommodative flippers. We usually use the plus and minus 2 diopters accommodative flippers. And these are the normative data that you require for accommodation assessment. NPA is, as we said, it is age dependent, and you calculate it based on the formulas. The MEM retinoscopy or the accommodative response would be 0.25 to 0.75. Accommodative facility is 11 cycles per minute and relative accommodation. NRA is plus 1.75 to plus 2.5 and PRA minus 1.5 to minus 2.5. So we can group these data or values that we have got into positive fusional vergence data, which includes the positive fusional vergence, vergence facility, NRA, binocular accommodative facility, NPC, and MEM retinoscopy. And you find that in exophoria, the positive fusional vergence group of data will be lower than expected, and MEM and fuse cross-cylinder will show over-accommodation. And the negative fusional vergence group of data, the NFV, the negative fusional vergence facility, the positive relative accommodation, NPC and MEM retinoscopy data together form the negative fusional vergence, and patients with esophoria and asynopia, the negative fusional vergence group data findings are lower than expected, with fuse, cross-cylinder and MEM showing under accommodation. So for this child, we had exophoria. You need to analyze the positive fusional group data. If it is low, calculate the accommodative convergence by accommodation ratio and compare the near and distance phoria. Distance greater than near, it would be a case of divergence excess. Distance equal to near is basic exophoria, and distance less than near would be our case. In esophoria, you find that you analyze a negative fusional vergence group of data, and if it is low, you calculate the AC by A ratio and compare the distance and near phoria. Distance greater than near would be divergence insufficiency. Distance equal to near would be basic esophoria, and distance less than near would be convergence excess. If you find that the child has no significant phoria, then you have to suspect anomalies of accommodation. And you do the test that approbe the ability to stimulate the accommodation. If they are low, it is accommodative insufficiency. That test probing the ability to relax the accommodation are low, it is accommodative excess. And test probing the ability to stimulate and relax accommodation, it is accommodative infacility. And in some cases, you find there are no phorias or no accommodative problems, then you need to suspect cases of fusional vergence dysfunction. So now, once you have come to the diagnosis of convergence insufficiency or the particular binocular vision abnormality, the first thing that we need to do is to rule out underlying organic causes, because some organic causes can very well present with this binocular vision. They can simulate binocular vision abnormalities. For example, vergence dysfunctions can be seen in close-held trauma, psychogenic causes, Graves, multiple sclerosis, anemia and measles in children, and other neuroophthalmic causes, and that needs to be mandatorily ruled out before we start on a treatment of binocular vision abnormality. Accommodative insufficiency also, we have a battery of causes, and all these need to be ruled out before you diagnose it. Now, so what is the treatment modalities that we have? Based on the conditions that we said, we can either have vision therapy, or you can use prisms, or you can have added lenses. The phases of vision therapy would be: in phase 1 is to normalize the accommodation amplitudes, develop voluntary convergence, and normalize the positive fusional vergence. In phase 2, it is the ability to stimulate and relax accommodation and train the vergence facility. And phase 3, integrate accommodative facility to oculomotor training. So we have a lot of vision therapy instruments which can be used for these. The simple ones that we know for the convergence would be our pen push-ups. You have the dot cards, CAD cards, and Brock string exercises can be used so as to simulate the convergence. The accommodative disorders would be benefited by using the heart chart, where you can ask the patient to read a near target and a far target. Thereby you are sequentially stimulating accommodation and relaxing the accommodation. You can use accommodative flippers, plus and minus lenses, and when the patient uses this also, there is stimulation and relaxation of the accommodation. There are special instruments like the red rock, accommodative hoping cards, and loose lens rocks that can be used in cases of accommodative problems. Plus lenses can also be used in cases with accommodative insufficiency, and that should be titrated based on the NRA and PRA values of the patient. So thank you so much for the patient listening. Binocular vision anomalies need to be ruled out in all cases of double vision. Thank you.
Thank you, Dr.